I'm Rob Breiman and from Emory University in Atlanta, and this is Megan Carey from the Gates Foundation. And we're very happy to be talking about this, this issue this afternoon, which is basically a systematic evaluation of disease burden in Africa and in Asia. Before the advent of the 21st century, there was very little systematic data on typhoid disease burden. And then in the early part of this century, the IVI and its diseases of the most impoverished nations collected some data from Asia that was pretty pivotal in turning people's heads about how important typhoid is. But a number of questions remain. There had been studies through what was called the TSAP program in Africa, which also shed light on the topic, but there's a ways to go, as you'll hear during this session. And so we'll begin now with a pretty full session. We hope speakers will keep to time and that we'll have time for questions and answers. So I'll turn it over first to Megan.
Thanks so much, Rob. So our first speaker today will be Florian Marks from the International Vaccine Institute. He's the PI on the CETO study and formerly of the TSAP study, and he'll be discussing the epidemiology of typhoid fever and NTS in Africa.
Hello, everyone, and thank you for giving me the opportunity to speak today here. So as Rob just mentioned, we started a couple of years ago with the Typhoid Surveillance in Africa program, which came out of the fact that there was not enough disease burden data available in Africa. So we had a meeting in Kilifi in 2009 where major stakeholders came to discuss what needs to be done. And from that meeting, we then moved the typhoid agenda forward and decided that there was a need for a typhoid study which is standardized and be conducted in several African sites to see whether typhoid and also non-typhoid salmonella disease is a problem in Africa, and then move that forward to vaccine introduction. So what we did in the Typhoid Surveillance Africa program is to look into invasive bacterial bloodstream infections. We enrolled patients in 13 African sites, and all the procedures were standardized. We had inclusion criteria standardized, which were febrile patients, lab procedures were standardized, case definitions were standardized, and we conducted healthcare utilization surveys to look into the proportion of patients going to our healthcare facility, and also data management was standardized. Typhoid and INTS cases were then confirmed using blood culture, so we equipped study sites that didn't do blood culture diagnostics at that point with a machine. And what we found for typhoid fever is a high burden mainly in Ghana, in Burkina Faso, and in Kibera in Kenya. And in some of the settings, the rates were similarly high than what we saw in the DOMI program in Asia. And for INTS disease, this was a bit related, how does this work, to malaria. What we saw is that INTS disease is highly correlated with the occurrence of malaria, which was also a lot in West Africa. In Burkina and Ghana, we saw highest incidences for INTS disease, and then also now that's the highest incidence areas. And then the other sites, especially in East Africa, they're all high altitude countries without malaria, so they didn't also have much INTS disease. And the three serotypes we found was Typhimurium, Enteric in Dublin. That was the most prevalent species for INTS disease. We looked also into the AMR profiles, and for both typhi and INTS, we found quite a number, 47 and 48% of MDR isolates, and they were mainly located in areas that have a high use of antibiotics and also use a variety of antibiotics in the countries. This was Ghana, Tanzania, and Kenya. Those data are all published. The incidence data came out this month, and also we have a method supplement in CID, which was published last year. And then we carried the data forward. There was an estimated disease burden for typhoid done by Vital Mugasale, and those didn't include the T-sub data. So when we updated the model from him, the incidence in East Africa decreased a bit from 526 to 376 in East Africa, but increased significantly in West Africa, almost threefold than previously thought. And the overall incidence in Africa increased to 328 per 100,000 based on those new estimates. We also looked, and that came out in a WHO meeting yesterday morning, and it's also important for the SAGE recommendations later on this year, into the INTS and typhoid burden in children and infants, and we looked into T-sub data further. And what I can see on this screen, but you may not be able to see on that screen, is that there was very limited typhoid burden in the 0 to 1 years of age group, and it starts basically at the age of 12 months. And when we looked into the T-sub data and if a potential typhoid vaccine would have been introduced together with measles 9 months, we would have captured every typhoid case except one from all the T-sub sites. For INTS, this is different, and it's, according to literature, also the way that the INTS burden is very high in the younger age groups, and then decreases the older the kids get. As I mentioned before, we saw this correlation with INTS and malaria. So that was a cross-site investigation, and we found that malaria is highly correlated with the INTS occurrence. So, and I want to spend 1 minute on the Vidal test for this audience. So what we have noticed in all of our study sites that many sites are using the Vidal test, which is not necessarily the best diagnostic test on the market because it doesn't show acute disease and it's not really specific. And it's often done in a single tube, although you need several tubes. So when we went to Sudan, which was one of the T-sub sites, we investigated with the Ministry of Health where would be potentially the best study site to conduct typhoid surveillance. And the Ministry of Health came up with 4 healthcare centers in Wat Medani, and they said after malaria, this is the highest typhoid burden area in that city. So we conducted T-sub surveillance there. We set up a laboratory, we purchased a blood culture machine, and so forth. And among the 700 blood cultures we did, we found not a single typhoid case in Sudan. So the Vidal test did not reflect anything what we found in the blood culture-based surveillance. So lessons learned from conducting typhoid surveillance in Africa were many, among which I have some listed here. First of all, we found that typhoid is very much different in different areas of a country. So this leads to a selection bias. Where do you choose your site? Where do you conduct surveillance? How much can you extrapolate data from one site to another? Another issue was local lab capacity, since surveillance is very much dependent on blood culture-based diagnostics. Many of the labs, especially in rural sites, would not have capacity to conduct such a surveillance. And then, of course, we had the typical challenges coming with a multi-center study that sites needed to adhere to protocol and follow up the procedures. Difficult was also in major hospitals to enroll all febrile patients coming through the entry doors. But bottom line, I think typhoid surveillance is the limiting factor is the diagnostic tool. We don't have anything that you can use in a remote site to look where you actually think typhoid would be a problem. So that was a TSAP program from 2010 to 2014. Was the first program that provided data standardized across 13 sites in Africa, and those numbers are used also for the Gavi for the SAGE meeting later this year. And the results we showed in the TSAP study is typhoid is in Africa. There are some sites with a high burden, some sites with a lower burden. There is a need for preventive measures that include vaccines in some of the settings, so we need in next steps find out what such high-risk settings could look like. And the TSAP study then moved forward to the severe typhoid in Africa program that Justin will present shortly after. So here we are looking into the severity of disease and mortality and the long-term effects in a couple of sites. So in summary, both typhoid and INTS are major cause of invasive bacterial febrile illnesses in the selected sites of the TSAP study. And those data will be used by key stakeholders like the SAGE meeting that is here to make decisions on where and for whom vaccines should be introduced. And in the next study, we are working on severity and mortality and also cost of illness of typhoid in Africa. So I want to thank a large number of people for making this study possible. That's the country collaborators who did an excellent work to make this study possible. We have a steering committee that oversees the study. We have lots of international partners working together with us, and there are lots of studies which are added on. And I would like to thank also the project team at the IVI and the Gates Foundation for funding this study. Thank you very much.
Thank you, Florian. I think in the interest of time, given the number of speakers and the interrelatedness of the topics, what we'll plan to do actually is to go through all of the speakers and then hold time at the end for questions.
Sorry, Carey.
Thanks.
Okay, so our next speaker is Justin Im, who's also from the International Vaccine Institute, who's going to give us an overview of this thing called CETA.
Thanks, Rob. Good afternoon. It's a pleasure to be with you here today. Today I'll talk a little bit about the Severe Typhoid Fever Surveillance in Africa program. I'm actually very pleased that actually representatives of all of the countries are here today from this program, and I hope also to do good by you as we go through this study together. Okay. So thanks to Florian, the study PI, for teeing up this talk quite well. The establishment of the typhoid fever surveillance network in sub-Saharan Africa really provided a lot of momentum to continue typhoid fever-related studies in this region. As Florian mentioned, some of the results of the TSAP project really helped to bridge or narrow that gap in systematically collected population-based blood culture confirmed typhoid fever incidence studies in the region. But that still leaves us with the question of severity of disease. There's still a lot to be said about burden and looking at a higher granularity of how severe forms of typhoid outcomes, including fatalities, really impact disease burden. And in this, we're going to look at things like the potential evolution of genetic strains that confer potentially higher pathogenic outcomes, looking also at mechanisms of transmission, looking at risk factors that might predispose certain populations to more severe forms of typhoid fever, as well as looking at the economic burden, which is also very important. So consistent with many of the trends that we see in the typhoid fever world, much about what we know comes from Asia first. So looking at the severity of typhoid fever, there have been several studies published looking at characterizing severe typhoid fever in Asia. This paper here, published by Chris Perry and his team, looks at 581 hospitalized typhoid fever patients in Vietnam. And they go on to characterize some of the demographics and also the symptoms that are highly prevalent in these cases. Interestingly, when we look at the risk factors that might be associated with severe forms of disease, a lot of the things that we might hypothesize were actually, when looked in conjunction with other studies from the region, found to be sort of variable, and there weren't really any conclusive evidences for things like sex, for age, or even interestingly looking at multi-drug resistant phenotypes. So this was not found to be positively correlated with severe typhoid infection. However, highlighted in red there, they did find that infection with an organism that had intermediate resistance to ciprofloxacin was positively correlated with severe disease outcomes. And looking at other studies that have been published from the region, and also in line with some of the earlier talks that we've seen today about the different lineages conferring potential multi-drug resistance, is this emergence of this H58 S-typhi haplotype. And if we can make a connection, what we might suppose is that actually severity of disease might actually be related more to the genotype of the strains itself, and this is also supported. And so this is interesting for Africa, as we see now through other colleagues. Here's a table presented by Nick Feasy in Malawi. They show a pronounced increase in the prevalence of S-typhi multi-drug resistant strains. In particular, after looking at a subset of the isolates identified here, they did find actually the emergence of this H58 lineage in Africa. I'll just whiz through these quickly. I see I'm running out of time already.
Add another 5 to that.
Add another 5? Okay, thanks, Rob. So this is a phylogenetic tree prepared by Sayan Park, adding on to work that was done at the Okru and at the Sanger by colleagues there. This really I just want to highlight the fact that the red band there, the red portion of the phylogenetic tree, represents that H58 clade, and what we can see in the outer rims are actually the presence of isolates from that region, or from that clade present in Africa. So to bring our story full around, this slide was also presented earlier from Vanessa Wong and colleagues at the Sanger, looking at here the radial expansion of the H58 strain from the Indian subcontinent through to Africa, and this is consistent with what we've seen, and this might add some color to the story of severe typhoid in Africa. Okay, so against this canvas, we have what we call the Severe Typhoid Fever in Africa program. We're continuing 4 of the sites from the TSAP program in this secondary study, and we are including 2 new sites, one in Nigeria and one in DRC. Some features of the study are consistent with what we implemented in TSAP. So this is a standardized protocol. We tried to have a uniform inclusion criteria as well as diagnostic, laboratory diagnostics. We also, and so this is so that we can have comparable data which can eventually feed into hopefully extrapolated models that can help us to predict disease burden throughout the continent. The CETA objectives are multifaceted. Rather than going through all of them in this short amount of time, I'll just highlight some of the major objectives. The first is to estimate the burden and severity of invasive salmonella infections. We're also going to characterize the AMR profiles of the isolates that we find. In addition, to observe fatal outcomes, we've selected areas that are underserved outside of our catchment populations where blood culture surveillance is not ongoing, to see if we can sort of enhance our knowledge of potential mortalities caused by febrile illnesses where we don't intervene through surveillance. We're employing long-term follow-up of both cases and controls, and this positions us to look into immunological patterns following acute infection. We're very happy to be teaming up with Cal McLennan at the Jenner Institute at Oxford. He'll be looking at some of the cell-mediated responses. Also, Ian Day from the IVI and Stephen Baker from OCRU will be looking at antibody responses following acute infection to typhoid and NTS respectively. We also have a component where we look at salmonella carriage amongst households of cases. We're also looking into estimating the burden, the economic burden of typhoid fever, also looking at some of the long-term sequelae. And finally, as Stefan presented very nicely earlier today, some of the results from the PCR salmonella assay from Bangladesh. We're recreating this study in 2 of our sites in Ghana and in Burkina Faso, and we hope to have some data from Africa to support what they've presented in Asia already. So this is a very unuseful slide, just showing the overall implementation strategy of one primary health facility in Burkina Faso. Let's see if the animations work. Okay, here we go. To zoom in, I'll just very briefly give an outline of what we're trying to do in CETA. Also aware of the fact that in each of our countries, in each of our sites, there are certain characteristics that make it very difficult to completely standardize the protocol, but we do our best to make up for those within the protocol. So patients from the catchment area who are attending the CETA designated primary or secondary health facility or tertiary facility are screened for eligibility. We enroll patients who meet our fever criteria, which is defined as current fever measured as 38 degrees tympanically or 37.5 measured axillarly, or fever of history, which is defined as 3 or more consecutive days of fever within the last week. In particular relation to our tertiary health facilities that have the capacity to do surgeries, special cases which are those with intestinal perforation suspected due to typhoid fever are enrolled. This is regardless of what their blood culture, and they're considered to be cases regardless of what their blood culture results are, and regardless of where they reside, whether or not it's outside of the catchment area. Eligible patients are approached for informed consent. Those who are consented are then enrolled. We collect patient background information, and also we assess, we do a clinical assessment at that point. Finally, samples are collected. Most importantly, we collect blood for blood culture. We're using an automated system throughout all of the countries, the BACT alert or the BACT-Tech, which many of you are familiar with. We collect some additional blood for some additional clinical assessments, including whole blood count, liver and kidney functions. We do a malaria smear, and we also collect some blood to store in our biobank. Urine is collected to look at some antimicrobial metabolites to get a better picture of pre-drug treatment. We collect stool. We collect native stool for storage to do some exploratory analysis later on to see if we can find any febrile-causing pathogens that were not cultured. And we also collect oral pharyngeal swabs in some sites to look at strep A within our febrile populations. Finally, in our tertiary sites, we also collect tissue and peritoneal fluid to look at if it's possible to isolate any bugs in our perforated cases. Samples are sent to the lab. diagnostics are performed, relevant results are sent back to the physicians, and positive Salmonella species or those patients with suspected perforations due to typhoid are then enrolled in our next phase. And also, I'm running out of time again, so just get through this quickly. This just shows the process of enrolling our household contacts and our neighborhood controls, which are important for follow-up. The follow-up schedule is presented here. For cases, we visit them 5 times over the course of 1 year at the one-week period, 4-week period, 3 months, 6 months, and after 1 year. For cases and controls, we visit them and sample them after 6 months and 12 months. And during these follow-up visits, we also conduct the cost of illness and long-term socioeconomic impact examinations. This is just an illustration of the protocol in the field. We have a healthcare utilization survey. I'll skip through this because we don't have time. This is the healthcare utilization being done in Madagascar. And given that we have such a wide spectrum of objectives, we do have actually many integrated outcomes that we hope to achieve. What I'd like to highlight is one here. We try to aim to collect quality and standardized data, which will help to go towards developing and validating an S-typhi risk and disease burden prediction model for sub-Saharan Africa. We think this is important given the fact that we expect important decisions on the investments for typhoid fever intervention policies to be made very, very soon, and we hope that this tool can add to the arsenal of evidence that will be used by those who are writing typhoid policy. Finally, the CETA surveillance network provides a rich environment for collaboration, and also cannot finish without acknowledging all of our partners. Florian mentioned all of them before. Especially want to acknowledge our country collaborators, since many of them are here today, without whose hard work we cannot have any of this completed, and whose friendship we cherish very much. Thank you very much.
Thank you, Justin.
Okay, our next speaker is also from the International Vaccine Institute, Siyun Park, will give us a readout on some of the initial data from the 6 CETA sites.
Okay, so I'd like to share with you our preliminary first data from severe typhoid fever surveillance program in Africa. But before that, maybe I could do a quick overview of our study sites, starting from Madagascar. So in Madagascar, we are targeting 4 public health care facilities, 1 primary health center in Emory commune, which is about 1 hour drive away from Tana City, and 3 tertiary hospitals that we added in CETA that we hadn't had in TSAP before for screening of the severe typhoid patients in Tananarivo City. The catchment area of Antananarivo City is about 2.2 million, and Emory is about 50,000, and it's a mixture of urban and rural setting. For Ghana, we are targeting 2 hospitals. One is Agogo Presbyterian Hospital, targeting Asante Akim North and Central District, and Kofanata Teaching Hospital, which is targeting Kumasi, which has the population of 1.7 million. It's also a mixture of semi-urban and rural areas. Burkina Faso, we are targeting 4 healthcare facilities, 1 primary health center, 1 secondary hospital, and 2 tertiary hospitals. So in TSAP, our previous study, we had run our study in Polesco and Yoko, and we have added the tertiary hospitals in Yagado and Charles de Gaulle pediatric hospitals for CETA. The population of Ouagadougou is about 4.5 million, and Yoko and Polesco is less than 20,000. And Ouagadougou is an urban city capital of the country. Yoko is semi-urban, and Polesco is semi-urban. Nigeria, we are targeting 5 public health facilities, 2 primary health centers, 2 secondary hospitals, and 1 tertiary hospital in Ibadan. They're all located in Ibadan. Our population size is 1.3 million. It's an urban setting. In Ethiopia, we are targeting 3 sites, Addis Ababa, Adama Wenji, and Wilayat Sodo, with the different population size. Addis Ababa with 3.2 million, urban setting. Adama Wenji is less than 60,000 people, semi-urban/rural. Wilayat Sodo is less than 200,000, semi-urban setting. So we are targeting 2 tertiary hospitals in Addis Ababa, and 2 secondary hospitals, and 3 primary health centers in Adama Wenji, and 2 secondary hospitals and 1 primary health center in Wilayat Sodo. Lastly, in DR Congo, we haven't run study TSAP there, so we have extended our collaboration in DR Congo, targeting 3 healthcare facilities in the western part of the country, in Kabuaya and Kandu and Kisantu. So looking into the primary data that we got, just focusing on Madagascar, Ghana, Burkina Faso, and Nigeria, because we haven't started the enrollment of patients in DRC and Ethiopia, which will start in June this year. So data coming from these 4 countries, we have enrolled total 3,118 people. Of those, 67 had perforations, and with 3 reported deaths, which is 5% of the perforations. Of the enrolled, about 86% had blood culture performed, and 128 was positive for all bacteremia. 60% was non-salmonella species, and 41 S. typhi and 10 NTS isolates we have found. Looking into country-specific cases, in Madagascar we had 2 perforations and 8 S. typhi, which was 30% of total blood culture positive bacteremia, no NTS from blood culture. In Ghana, we had 22 perforations, which were 3% of the enrolled, 28 S. typhi, which was 43% of the blood culture positive bacteremia, 8 NTS. Burkina Faso, 38 perforations, which was also 3% of the enrolled, 3 S. typhi and 2 NTS. Nigeria, we had 5 perforations, which was 10% of the enrolled, and 2 S. typhi, which was 40% of the blood culture positive bacteremia. And looking into the age stratified cases, we found that our preliminary data from CETA reconfirms our earlier findings from TSAP, whereby we find a higher burden of S. typhi, or more number of S. typhi strains found among children between 5 to 15, versus NTS, where much younger children, less than 5 or less than 2, had higher proportion of NTS positive out of the total NTS positive of all age groups. For perforations, we found that 55% of the total 67 perforations were above 15 years of age, and 30% of the 67 perforations were between 5 to 15 years of age. And I have 2 more slides, one from Madagascar and the other one from Ghana, comparing blood culture and stool culture results from the stool samples and blood samples collected from patients at enrollment, because we are also collecting these samples during follow-ups. But just looking into these samples and culture results from enrollment, in Madagascar we had enrolled total 1,015 patients who were eligible, and we had performed 1,001 blood culture, which was 99% of the enrollment, which showed 28 blood culture positive for all bacteremia. Of those, 71% was non-salmonella species. We had 8 S. typhi and non-NTS from blood culture. However, from the stool culture result, we have found 0 S. typhi, but 4 NTS from stool culture, which was performed in 985 stool samples that we have collected. And from Ghana, we have enrolled 796 patients and 100% blood culture performed. and we had about 65 blood culture positive for all bacteremia. 57% was non-Salmonella species, 28 as type A, which was 43% of the total culture positive bacteremia, and 8 NTS. In terms of stool culture performed, it was only 33% of the enrolled that we were able to collect stool sample and do the culture. So the data, as we run the study, we may find more about this in Ghana, but we found 3 S-typhi in stool culture, but no NTS in stool culture results. So those 3 S-typhi could be 11% of the blood culture positive S-typhi patients that we enrolled. So we had many challenges as we were running the multi-country studies in 6 countries, and within each country we had several sites, several healthcare facilities with different degree of services. So standardizing protocol across sites and also within Africa sites, CETA and SIB has been challenging, and also trying to accommodate site-specific considerations at the same time. It took a lot of efforts and led to sometimes a delay in ethical approvals. Screening of and enrollment of patients at tertiary hospitals is challenging because of the number of people that are coming to the hospital compared to primary health centers. Defining catchment area for tertiary hospitals, again, more difficult than primary health center. So in some of the sites, we went to the hospital and in our CETA entry points in the hospital, we tried to go through the hospital logbooks to check basic information about where the patients come from, to be able to draw the line for our catchment area. Healthcare assessment utilization survey in big catchment area like Ouagadougou or Antananarivo City is very challenging because we're talking about an urban population of more than 2 million, 1 million people with very complicated structures and housing systems. So in terms of sampling, it becomes very challenging and requires more sophisticated approach. Following up of cases and enrollment of controls and collecting stool samples, other logistical challenges we have faced that we try to solve together with our site collaborators. So in summary, 4 CETA countries we have started, so that's Ghana, Madagascar, Burkina Faso, Nigeria. Nigeria we just started last month, so actually the population data that has been presented, it's only 1 or 2 months. So given the short time period, I think in Nigeria we can probably expect a high proportion of population cases. But from the data that we have collected so far, we saw a significant number of populations in Burkina Faso. And we have been trying to address the challenges and to improve the surveillance across the sites. So we will continue the surveillance for another 1 year for the sites that already started, and for new sites for 2 years. And we are conducting healthcare utilization surveys to be able to generate the proportion to calculate the incidence of typhoid fever and INTS disease. And I'd like to thank all the site collaborators and the teams in Madagascar, Ghana, Burkina Faso, Nigeria, Ethiopia, DR Congo. There are so many people that I couldn't list here, but I'd like to really thank them for all their help in trying to address the challenges together. And also the other collaborators, Rob and the team in support, Sanger Institute, Professor Gordon Dugan, and Steve Baker from Okru, Ho Chi Minh City, and his team there, and Professor Kevin McLennan, everybody who's listed, and the Gates Foundation. Thank you very much.
Thank you very much, Seon. The next talk is going to be given by Jong-Hoon Kim, and there's a slight change in his title, which now reads African Risk Prediction Model, Mapping the Burden of Typhoid Fever in Africa.
Let's see. Okay, thanks. I'm really pleased to have this opportunity to present our work and look forward to hearing what typhoid experts have to say. Today my title is the African Risk Prediction Model and Mapping the Burden of Typhoid Fever in Africa. Oh, sorry. Let's go back. Okay. These are topics. First, I'm going to show a couple of examples of these burden maps to give you an idea of what kind of maps I'm talking about. And then I'll describe the how we can generate those maps. And those two will serve as an introduction, and then we move to our question of mapping the burden of typhoid fever in Africa. And then for the rest of the talk, I'll give some more details of two components that are needed to map the burden of typhoid fever. Those are model and inputs. And the model inputs will be typhoid occurrence data and explanatory covariates. And the model I used is boosted regression tree model. And the results from the model will be African map of probability of occurrence and actual annual instance rate of typhoid fever. So first map shows the probability of occurrence of dengue. I think this has a resolution of 5 by 5 kilometers. So we believe maps very useful because you can immediately recognize which area is a high risk, even within the national level. We can also make a map of instance rate. You can also recognize the spatial heterogeneity even within the country level. So we wanted to generate maps like this. And what this means is for surveillance studies, it means that we have better idea how to extrapolate the surveillance results, instance rates, to the rest of the sites we have no information about instance rates. So how do we generate these kinds of maps? Similar, how do you make predictions? We try to understand the data and outcome and the covariates. So in this case, disease occurrence will be outcome. So in the top left figure, I don't know if you see the red dots that represent typhoid, where typhoid has occurred. And the bottom, you see the covariates. So you take something that doesn't have a uniform distribution, but somehow has interesting distribution that might have some influence on disease occurrence, and try to find the model. You're trying to find the relationship between those two. And then in this case, if you take occurrence as a binary outcome, you could do like simple logistic regression to get the predictive probability of occurrence. And then some of the occurrence points may be surveillance sites, so you have a magnitude information of an instance rate. So you took those, and then doing the similar process, you can get the instance rate. Or you can actually go from the predictive instance to the instance rate. Later I'll show later. So what it means to our question of mapping the burden of typhoid fever, data is typhoid occurrence, but just geo-referenced, so we know the location. And also the variables are the geo-reference variables that might have influenced some typhoid transmission. And as I said, we used boosted regression tree model and also Bayesian hierarchical model. We'll have a chance to explain a little bit those two. And to identify, so for the next few slides, I'm going to describe a little more detail about data and model. So data, to identify the typhoid occurrence, we reviewed peer-reviewed articles from PubMed, Embase, and some news reports from ProMed. And as a primary analysis, we only included blood culture confirmed typhoid fever. And we identified geographic coordinates using Google Maps. And we included as a baseline primary analysis, we included all the typhoid occurrence records from since 1950 to up to 2015. And then typhoid occurrence standardized by year, meaning even within the multiple occurrences, we treat them as a single occurrence. Probably because most of the records have finest resolution you can find in terms of time is year. So we standardized by year. Just to give you a glimpse of records we have reviewed. This dot plot shows size of dots, shows the number of records, meaning the peer-reviewed articles or news articles we have reviewed. And a vertical axis shows number of countries. So in total, we have reviewed around 1,500 records for 35 African countries. and the horizontal line shows year. So if you top row shows Africa total, it seems there seems to be a trend. We have an increasing number of typhoid reports, but there's a lot of heterogeneity across countries. For example, if you just below the Africa total, there is Zimbabwe. You only see reports since 2010. At the bottom, Algeria, you see lots of typhoid reports in 1970s and 80s, but no reports after 2010. If you plot that on a map, the Algeria, actually top part, you see a blue dots, meaning the typhoid occurrence in the past. And then in the middle part, you see some yellow and green dots, meaning the more recent typhoid transmission events. So we have total in 688 typhoid blood culture come from typhoid occurrences. And this shows one example of covariate that I'm talking about. So this is annual precipitation. So you can just, it's difficult to explain, but you have a distribution like this map. And this is one covariate trying to predict typhoid occurrence. And we use additional covariates. Okay. Like we use annual mean temperature or altitude. That's environmental variables. The bottom row, you can see some of the, you can call like socioeconomic variables. So travel time, it's very high correlation with the urbanity, people think. And the gross sale product, that's like a GDP per capita, but on a square grids. So, and I don't have a map for like a variance of precipitation that's used, but also I use those covariates to predict in the model input. Okay, so these are the model inputs. Eventually we have this kind of map on a grids. So for each cell, we have information about the covariates we have just reviewed. And also for some cells, we have information about typhoid occurrence. For some other cells, we have no idea whether typhoid had occurred or not. So these are the model. This one is the final model input. And what we used is a boosted regression tree. It's, for those of you who are not familiar with this, it's a classification decision tree. So if you look at the left figure, it's a simple decision tree. As an example, we have two covariates, like precipitation and temperature. Let's say precipitation is less than 3,000 and temperature is lower than 20. Then you get the sum probability of typhoid occurrence. And you can go down to different pathway. And in terms of three-dimensional way, you can use the right figure. But this is an example of one tree, but actual model has multiple this kind of trees to combine them to get a better prediction, like over 1,000 trees. This is the results. So I'm going to show a few different maps from now on, and those are all same resolution of 5 by 5 kilometers. These are the maps. So this is the predicted probability of typhoid occurrence. We see if you remember like dengue and malaria, we see lots of heterogeneity even within a country and overall African continent. One way to how well our model work, one way to look at is the title. One way we do is a tenfold cross-validation, which is just you take the 90% of data and try to predict the rest 10%. And those of you who were in the morning session, I think Thomas mentioned the AUC score. So AUC score is a variable it varies from 0 to 1, and around 0.5 is random. So you randomly select and you get around the 0.5, and it's moved toward 1, and it has some of the selection power. You get the sensitivity and specificity. And so we compare with a null model. In this case, null model is you can call it distance model. You try to predict disease occurrence just using the distance. So it's an idea that it's actually there are typhoid occurrences are cluster, so you can actually predict. But in this case, I use some stringent condition that null model actually don't predict well. But our model with the covariate predicts a lot better than the null model. And as I mentioned, this one is overlaid, typhoid predictive probability overlaid with T-cell surveillance sites, just to stress that some of the current sites actually are surveillance sites. You have information about the instance rate. And I try to find some instance relationship between the instance rate, the vertical axis, and the horizontal axis is probability occurrence that I predicted. And this one is a sample from the fit model. And the dark gray area is 50%. And light gray has a 95%. And so our model predict most of the observation within the 95% range. If we apply that to probability of occurrence, you get the instance rate. So these are the results we get. Similar heterogeneity. And you apply that, if you want the annual instance, you just simply apply that population counts. Then you get the number of annual instance for the same resolution. And I'm showing the country border to remind you that since we have that resolution, you can, if you want the country level estimate, you can just sum them up to get the country level estimate. So in conclusion, this is my last slide. So we have generated, some have predictive power of maps that have some predictive power, have probability of occurrence and instance rate of typhoid fever. We see lots of heterogeneity in the overall continent and within a country level. And one thing that I want to touch on is that our covariates we used, maybe you can think other more relevant covariates, risk factors like access to clean water. We haven't included those because just those covariates are not readily available in a 5 by 5 kilometer resolution. So that's our future plan. Yeah, that's it. Thank you.
Thank you, Jong-Hoon. I have been a early speaker in long sessions before where there's been mass Q&As at the end, and no one ever remembers that I even spoke by the time the Q&As come. At least that's what I tell myself. That's why I don't get questions. So I think we're going to take a break for right now, so you can, we'll take a few breaths and open the floor for questions for the first 4 speakers.
Yes, thanks a lot. My name is Adam Akulian. I'm with the Institute for Disease Modeling in Seattle. Just a question for the last speaker about the functional form of the relationship between your covariates and the outcome. We were talking earlier about how precipitation in some contexts is predictive, is positively associated, whereas in other contexts it's negatively associated with typhoid fever.
Right.
Did you use any nonlinear, or did you use incorporate any effect modification based on context?
Okay. Yeah, I didn't have time to explain the details of the modeling, but it's very much nonlinear. We didn't really use any statistical model form. It's a boosted regression tree. You make a classification, right? If you actually see the relationship between, for example, precipitation and risk of typhoid or predicted probability of typhoid risk, it's like, no, you can never imagine any functional form of those. Like, it's too complicated. Although just way too, it's just you have to see the distribution relationship. So we didn't really force any kind of relation between the two, just model stochastically generate, try to find the best fit. So it's maybe non-satisfactory in the sense because we want to have a simple relationship somehow, but it's actually model, try to find the best relationship between the two.
Okay, brisk questions and brisk responses. Cal.
Jong-Hoon, with the modeling, have you taken account of the fact that the data that you've used to start with have occurred at different times, and typhoid fever is patchy and can come and go? And have you got any plans to do a model for NTS as well, which would be very nice to see?
Thanks. That's a great point. No. Okay. Short answer is no. I haven't tried that. But this one? Really? Okay. One way we did actually try to, we actually want to see the real relationship, then we have to connect with the occurrence time point. For example, occurrence in certain 1968, and try to identify relationship with precipitation in 1968. But we don't have those data readily available. So we just combine them in a cumulative instance. It's a cumulative risk over time, like 50-year period. So since we're using like 2010 projected precipitation, so we try to use most recent one, but not really separate much further. But thanks for your question. And NTS, yes, we did, yeah.
So let's go to Chris Perry.
Chris Perry, Liverpool. Just in relation to the severe typhoid presentation, just to say, so the question about whether H58 is associated with severe typhoid. So in the Vietnam data that was published, we actually have looked at relationship between H58 and severity. Data analysis isn't complete, but it looks like there isn't an association with disease severity. And I think the issue on the relationship between resistance and severity depends on the background of resistance in the population. So when MDR is common, MDR can be associated, but as quinolone resistance emerged and people in the community were using quinolones, then there was an association with severity with the decreased ciprofloxacin susceptibility. And hypothesis is that it's related to delays in effective treatment leading to severe disease.
Thanks, Chris. Yes.
So my question is for the last speaker. We were reviewing a similar risk map and risk prediction model for malaria in India in the Directorate of NBDCP. So the problem we found while adopting that model is that it's an auto-learning model, right? The more data you feed in such a model, it learns more and it predicts better. But the problem is at the micro level, means the factor we are looking, they are at macro level. But several micro level factors are there that predict the disease. So in such a model, when you prepare the model, say in Europe or say in any other country, and you are trying to apply that model in a particular small region, is it applicable from the implementation level perspective?
Is it a single question?
Yeah. Yeah. Because we are really struggling to find out the decision whether we should implement that or not.
It's a simple yes or no question.
The title much, something that how do we implement? One thing that I think if we want to use it in a particular setting, like all maybe transmission models, you need some adjustment. It's but this one is if you apply this one in some Asian country, I don't know if before I see the results actually, because there are specifics in different settings and you want to account for that too. So actually, I don't know.
So, okay, that's a good answer. Feel free to ask questions of any of the other panel members. We have 2 more minutes for questions. Iruka.
Iruka Okeke, University of Ibadan. Apologies, it's also for the last speaker. I do remember the other 3 talks. Do we have enough data to to produce a continent-wide predictive model. You do have, climatic similarities in the West African sites that lit up. But the other thing you have that's common among them is a greater density of blood culture machines than further inland. And so is there enough data, could you mine enough data from the literature to make a continent-wide map?
I didn't understand the blood culture connection between the blood culture.
You've got more teaching hospitals, more diagnostic capacities in the places that seem to be lighting up as have more typhoid. So is this confounding from data collection as opposed to actual distribution of the disease?
Yeah, that's a really great point, and that's a major limitation. So that's much care, actually really much care into the process of actually try to identify the actual location of typhoid transmission. That's the most difficult part of this data collection process. One thing we did was try to allow some of the variance, some of the like a random. So you allow, even if you found some case in a certain hospital, doesn't necessarily mean the transmission occurred in that hospital, right? So we allow some, there's some variation in the location, and then we just somehow predict uncertainty. That's what we did. But otherwise I have no solution for that. Yeah.
Florian, do you have a comment?
So I think when looking at this this model and having few data points from Africa, I think data points are not enough. But starting a model and then expanding it, and potentially, as we move the typhoid work forward, and there is like zero surveys being conducted at some point in more remote places, that would then overall and more feed into such a model and make it more robust. But I think with the current data points we have, it's very hard to extrapolate this on a country level or on a micro level.
So apologies to the other questioners, but we have to move on, but save your questions, because if the remaining speakers keep to good time, we may be able to bring you back up. Otherwise, you can approach the speakers afterwards.
Perfect. And with that, we'll switch gears. Denise Garrett from the Sabin Vaccine Institute is going to start by giving us an overview of the SEEP project.
Thanks, Megan. So my job here today is to just set the stage for the sites who will be presenting their own data. And by the way, this adorable little boy, his name is Asim, and you can read his story in the Coalition Against Typhoid website, in the Stories of Typhoid. So, this is. Today I'll just focus on an overview of the rationale of this study, and I will go over our objectives and methods. I will present just a couple of interesting results that we have, but you're going to hear the results a lot in more details with the site's presentation. So SEEP was actually designed to address some shortcomings of previous studies and fill knowledge gaps. There is very little data on population-based incidence rates, including burden of children under 2, severity of illness and clinical complication rates, case fatality rates, antimicrobial resistance patterns as it relates to clinical outcomes, the economic impact, and also very little data on burden in peri-urban and rural areas. With that in mind, on our mind, the objectives of SEEP were to characterize the burden of enteric fever in selected countries in Asia by describing age-specific population-based adjusted incidence, risk factors for severe illness. We're also going to describe the long-term impact of disease, including incidence of complications and case fatality rates. To those that were at the ASTMH meeting last year, Jeff Stanway, when he presented his model of disability, And what he shows is that death is the main cause of disability in typhoid. So we are really investing to describe case fatality rates well in the SIP study. We also going to be describing the evolving patterns of antimicrobial resistance for Salmonella typhi and paratyphi, the cost of illness from a healthcare and societal perspective, and explore the relationship, if any, between antimicrobial resistance, antimicrobial prescribed, and outcomes. Finally, a final objective is to establish a biobank of Salmonella bacterial strains and plasma. So going over the methods of the study was divided in 2 phases. Phase 1 was a retrospective data collection that was used to inform the design of phase 2. And it occurred in 4 countries, Bangladesh, Nepal, Pakistan, and India. We are currently conducting phase 2 of the study. We started in September 2016. It's a 2-year study. We'll go to August. Enrollment will go to August 2018. It's a multi-country, multi-site, prospective, population-based surveillance. And here is a description of the sites we are working on. India is not part of phase 2. India was just in phase 1. So we are, for phase 2, working Bangladesh, Nepal, and Pakistan. I'm listing the hospitals that we're working in each one of the sites. And the Bangladesh hospitals, they perform an average of 15,000 blood cultures a year. They serve the majority of Dhaka city population, that's 8.5 million people. Our catchment area in Bangladesh covers 3.4 million, and we also cover urban and peri-urban areas. In Nepal, the hospitals participating in the study, they perform an average of 5,000 blood cultures a year. They serve the entire Kathmandu Valley, that's about 2.5 million people, with 330,000 in the catchment area, and urban, peri-urban, and rural areas. Pakistan conducts an average of 38,000 blood cultures a year, and it serves the majority hospitals. The hospital we're working on serve the majority of Karachi population. That's about 20 million people. There is 3 million people in the catchment area, and also urban, peri-urban, and some slum settlements. So the study actually is divided in 6 components for phase 2. The first is a hospital-based surveillance that is incorporated into the existing site infrastructure. We have a healthcare utilization survey that's, as we know, it's a proven low-cost method to generate rates. It will be used to adjust the hospital surveillance and estimate population-based incidence. The third component is what we call enhanced laboratory-based surveillance. This uses existing laboratories of excellence to better estimate the clinical spectrum of the disease and deaths. And through this component of the study, we're also going to be able to look at the prevalence of drug resistance and also the consequence of drug resistance on outcomes. We have a patient follow-up that occurs with 6 weeks, where we're going to assess relapse, morbidity, and mortality. We have an economic evaluation that's look at direct and indirect cost of illness. And finally, the biobank, where we are keeping the isolates and plasma to be used in future studies, such as diagnostic testings. And here's a version of the study flow. We are recruiting in 4 different locations at the hospital sites. We are recruiting in the outpatient and inpatient, at the hospital, laboratory, and surgical ones. And also, as I mentioned, we are also recruiting from the laboratory networks that are outside from the hospital sites. And there are case definitions for each one of the locations. And our outpatient and inpatient patients, they will get a blood culture. We are not enrolling anyone without a blood culture in the study. And a sample of the outpatients is also getting a urine sample to determine the previous use of antibiotic. So all the blood culture positives, and they're also coming from the hospital laboratory and the laboratory networks, all the isolates are being kept in the biobank together with plasma. To those that are blood culture positive, we are also completing a questionnaire for the cost of illness and risk factors for not only typhoid, but for severe disease, including 10% at enrollment of risk factors, so we have some negative that we can compare with the positives. We're doing, as I mentioned, a 6-week follow-up for complications and death. And when there are, when there are complications, we do a follow-up chart review in person, a follow-up in person with the patient, and a chart review of the complications. And if there is death, we do a post-mortem survey. And just a couple of interesting results. And keep in mind of the limitations of this data, it's mostly retrospective data. And we have here over 5,000 cases. And also, besides of being retrospective, it's different data sources, and also it's case count, not proportion, in these graphs. But if you look, it's very interesting, and I broke down the burden under 5 and then under 2. But if you look at the curves, for instance, for Bangladesh, in Bangladesh, given, it is a hospital, pediatric hospital, so we have to take that into account too, but most of the burden is like in the curve under around 5 and 10 years old. The curve for Pakistan is shifted a little bit to the right. The median age for Pakistan was 9 years old. But it is somewhere similar to Bangladesh, but with a little bit older population burden in that in Pakistan. But when we look at Nepal, we see much shift to the right. The median age in Nepal was 20 years old, and it's similar to India, and Dipika is going to be presenting that data. But when I look at these curves, it's very similar to what John Crump described in his the global burden of typhoid paper, where you could say this curve looks like the high incidence population, Pakistan more of a medium incidence population, and then you see the curve shifting to the right in lower incidence population. Here is the antimicrobial resistance for over 4,000 isolates. And this, what we can see is a high level of resistance with the fluoroquinolones, low level of resistance for cephalosporin. We still see a considerable amount of resistance to the older generation antibiotics and MDR, but it's not shown in this graph, but we see a decrease of resistance to older generation antibiotics. So just to summarize, SEEP is a cost-effective surveillance approach that has collected patient-level data on over 5,000 enteric fever cases from 4 countries, and is expected to enroll over 3,500 cases prospectively for phase 2. And the ongoing activities in phase 2 will identify high-risk populations who would benefit from prevention interventions, measure the individual and societal economic burden of typhoid, describe risk factors for typhoid, including household water and sanitation practice, characterize the clinical outcomes and case fatality rates in different settings and subpopulations, quantify the relationship between antimicrobial resistance and severe outcomes, including mortality rates, provides baseline rate for assessing impact of future interventions, and also archive isolates and plasma for future use in a biobank. And finally, just the acknowledgement of, oh goodness, okay. If we can go back, just everybody can see the acknowledged. Thank you very much. This is.
Thank you, Denise. There, you're getting there.
Too late.
Okay. It'll be up there as you step back. So now for something really good. They've all been great. On the topic of approaches to community surveys for typhoid burden estimation experience from SEEP, we'll have Alexander Yu from Stanford.
Hi, everyone. I'm Alex Yu from Stanford. I'm working with SEEP in Nepal. And I'm going to talk about the healthcare utilization study, which is a subset, a portion of what SEEP is doing, and how it plays into the data that's generated from SEEP, as well as the assumptions that then go into it, and how that affects the outcomes and how we can interpret them later on. And so I'm going to talk a little bit about different surveillance strategies for typhoid burden estimation and the hybrid approach that SEEP is using. And then I'm going to briefly describe the healthcare utilization study, as well as some of the operational components of how we're going about sampling and the maps that we're using to do that, and then go over briefly some of the preliminary data that we have and the challenges we've encountered so far. So if we think about typhoid incidence estimation as kind of a pyramid, we think about the bottom perhaps as the total number of cases of typhoid in a population. And at the top of that pyramid, we think about perhaps the most severe cases of typhoid, things like deaths or intestinal perforation, other high morbidity outcomes of typhoid. And the goal really is to characterize these two parts of the pyramid, the typhoid incidence and then the morbidity and mortality associated with that. And two different approaches that we use. So one of them is a community-based active surveillance, and that tries to get at the bottom of this pyramid to get an accurate estimate of incidence. And this is often done using a large cohort, so establishing a large cohort in a population, and then following them very actively over time, so 1 to 2 times a week or more often, trying to track everybody who has a fever and then collecting blood and testing for typhoid. This has its own advantages and disadvantages. An advantage is that this is a direct estimate of the incidence of typhoid and can really capture some of the mild cases of typhoid that might otherwise be missed. Disadvantage, though, is that it's very time intensive and very resource intensive and can be cost prohibitive and thus hard to implement over long periods of time in larger populations and more globally. Another disadvantage is that it does affect the outcome of these cases. If you have people who are getting enrolled and identified with typhoid, then they're also being treated earlier and perhaps influencing how morbidity and mortality comes about. So another estimate or another approach is to do facility-based surveillance. And this is identifying labs or hospitals or other facilities, trying to enroll people who come in who meet a case definition that could be like typhoid, collecting blood, then testing them for typhoid, and then you follow their outcomes. This also has advantages and disadvantages. The advantages being that you're not affecting the natural history of the disease, so you're getting a more accurate estimate, perhaps, of morbidity and mortality. It's also cheaper, less infrastructure is needed. You don't have to do the active going from house to house over a long period of time. But disadvantages also exist. This is focusing on the severe cases and probably misses a lot of the mild cases in the community, and so is really not the best way to get an estimate of disease incidence in the community. So if we think about the other layers of the pyramid that might be in between the top and the bottom, we can think about perhaps a different way to approach typhoid surveillance. And so if we just walk through the pyramid, on the very bottom again is the typhoid cases in the population. And some percentage of that population is going to seek medical care. Of those, some of them are going to present to the facilities or the surveillance sites that might be enrolled in a study. Of those, some of them are going to get blood cultures performed. A percentage of those are going to be blood culture positive, and then some of those are going to have some degree of morbidity or mortality associated with it. So if we think about those different aspects of the pyramid, we can think of a hybrid approach, which is what SEEP is doing, to get a better estimate of the top and bottom of the pyramid. So the facility-based surveillance that we heard about is really a lab and hospital network here that is trying to get a direct estimation of the top of the pyramid. The bottom of the pyramid is where the healthcare utilization study comes in. And so this is a household survey, a cross-sectional approach that's trying to get an idea of if you were to be sick with fever in a way that would be consistent with typhoid, would you go to a hospital? And if you would, where would you go? And once you know these layers of the pyramid, you can help estimate down the pyramid to get an idea from the facility-based surveillance how you can extrapolate that to the bigger population as a whole. So an example, so if we assume there's, we're trying to identify X here, so the bottom of the pyramid, the number of typhoid cases, and we have a total population area of 100,000 in our catchment area. And then from our facility, we know there's 50 cases that we've identified as blood culture positive for typhoid. Then we might think that the crude incidence estimate is 50 cases in 100,000, so kind of a medium burden setting. However, if we then, through a healthcare utilization study, figure out that 20% of the population is actually going to the hospital, then that actually changes the way we think about that 50 cases. So if we were to adjust for that, we would multiply the 50 cases by 5, because only 20% are showing up to your hospital, then we're actually looking at 250 per 100,000. So this is, obviously a different number than the 50, and perhaps a more accurate estimation. So this has its advantages. It's less resource intensive than the active surveillance, because we're not going door to door and blood sampling everybody who has a fever. And it is still able to capture the severe cases and complications because we're not interfering with the natural history. People aren't being told they have typhoid and then getting antibiotics because of it. And so perhaps it's a better estimate of population case rate than just using the facility-based approach. Disadvantages are that it may still fail to capture some of the mild cases. This is still extrapolating from the fever or the typhoid cases that are identified at the facilities. And it does introduce uncertainty. So at every level of that pyramid, as you walk your way down, there's different biases and estimations that are going into it. So you're extrapolating and perhaps having all sorts of new levels of uncertainty that are going into it. It still requires blood cultures and the laboratory and facility infrastructure that you need to do the facility-based surveillance. So in Nepal, the healthcare utilization study is based on identifying a catchment area for the 2 hospitals that we are using. So this is a map of Dhulikhel Hospital, that's the red cross in the middle of the map. And looking retrospectively at the last year of typhoid cases that went to that hospital, we identified where 60 to 80% of those cases came from, and then use those as the geographical area that we were going to say as our catchment area. And so then we set about to do a cross-sectional household survey to understand who was coming in with, or where people are going for their fevers, if they are going in for fevers. And so once we had our catchment area, we overlaid a grid and with equal size squares, and then we randomly chose clusters from those grids. Within each cluster, so these are those little squares blown up, our goal was to sample every single house. And to do that, we would go back to each house 3 times on 3 separate occasions to try and maximize our enrollment. And you can see all those little pink boxes are buildings, and may look simple here, but the density may be widely variable. Some of those might be apartment complexes with 60 people living in them, and so it could be really easy to lose track. And so we wanted to come up with a system that was able to help us coordinate what we've done already, as well as coordinate on the ground logistically between surveyors. And so we used the real-time GPS system that overlaid a map that was practical for the surveyors to use, and was also able to sync up with each other as they went around on the field in real time. And this also gave us the advantage of generating these geospatial level data that was geo-referenced here in terms of where the surveys are happening, what still needs to be done, etc. And there's different ways to do this. In Kathmandu, which is a much denser area than the Dulakel area, which I just showed you, it runs into different issues if we were to use a square-based grid system. For instance, if you had a four-story apartment building with many apartments, you're going to run into trouble where half of that apartment may be inside the cluster or not. And so here we're using streets as natural boundaries to more easily have buildings fall in or out of there. So lots of logistical challenges, some being the Nepalese terrain. So the map may look simple, but within each of these clusters you might have a mountain range in between that obviously makes things a little bit trickier. Safety issues with a single surveyor being by themselves, or a male or female being by themselves, especially in the setting of some of the people who you're interviewing may be scared off by a random person coming up to their household. And then people being away from home, and so that changes the way we're able to sample and what times we can go. And some issues with the technical aspect in terms of the satellite resolution and precision that we have. So other biases and sampling issues. So longer recall period, we're using 8 weeks, which is a relatively lengthy time for fever identification. That can introduce biases in recall, but is more efficient. And then if the surveyors are telling them they're from a hospital, they may influence their decision making or what they're answering, and that's can have its own issues too. We also may be sampling less severely ill patients, which we are attempting to adjust for. So just really quickly, the preliminary data, we've done 2,000 houses so far, and about 95% of those have actually responded, which is great. Only 1.5% have declined. And looking at the fever, these are just two quick tables looking at fever responses so far. About 4% of the population has had a fever, and most of that's been in the 0 to 4 age group. The population sample has been pretty evenly distributed, male and female, but majority of the fever cases have been in the female population. And of those who had a fever, 80% were taken to a healthcare facility. And only 16% were taken to Dulakel Hospital, which is where this data is coming from. And just lastly, to acknowledge the many people who work on this, most of all Jason Andrews and Isaac, and also to Deepesh, Krista, and Rajani, who are on the ground doing work, keeping this running, and then to the team, the field workers and the surveyors, and to the SEEP leadership and the rest of the SEEP team. And special thanks to Sabin and to Bill and Melinda Gates for keeping this going and helping support us.
Thank you, Alex. Next, we'll hear from Samir Saha, who will be presenting Salmonella typhi and paratyphi in Bangladesh and antimicrobial resistance.
Okay. Good afternoon. Okay, wonderful. So I'm representing SEEP network, in fact. So Denise really set the ground for us very nicely. So I'll be just limiting my talk on Salmonella typhi and paratyphi and their drug resistance. So just a little bit about the progress we made and the milestones at this. If you look at these, we started in October, but only one hospital, an inpatient department, and then we moved to the outpatient department of the same hospital in November, and then we moved to the second hospital again on the inpatient department, and in February only we started the outpatient department of the second hospital that we did, in fact. So I'm sorry. Okay, so what we got from there, so these are the locations of our site, and then if you can see that we have 2 hospitals, and also we have 3 private diagnostics facilities. In fact, those are outpatient-based diagnostic facilities, and we are also getting more cases from there. Subsequently, what we had got from there, so from the hospital number 1, these are the number of cases who are being triaged from the registration desk sent to our study physician, and those are the cases who were eligible by the study physicians, confirmed eligible cases, and then the culture done from this number of cases, and then subsequently we got the cases who were positive, and these are the number positive cases from hospital number 1. The second hospital at the same time, we got 30 cases, but it started late. And subsequently, we got also enrolled some cases in the hospital who really could not really did not fulfill the criteria of typhoid, but clinicians really suspected, and then we got in the blood because all the stuffs are sitting in the lab, and we get all the information the real time from the lab, and they also got enrolled in the study. And also from the hospital network, we get the number of cases, and all together, we have got 345 cases during this about 4 months time period. And among those, from where these cases are coming, if you can see that the cases are coming from all over the country. They're coming all the way from north and all directions, in fact, but we have also, in addition to getting more number of cases to understand the severity and all other things, but we also want to understand the disease burden, that means the incidence calculation. So if that is our catchment area, these are the numbers who are coming from the catchment area. So all the cases coming to the hospital, 80% of them are coming from the catchment area. So that's what we know. What we don't know yet, that we do not know really what percent of the catchment area population are seeking care in the 2 hospitals. Once we know that, we'll be extrapolating that, we'll be understanding the incidence, doing the incidence calculation. But by that time, let's go to the typhi and paratyphi in the hospital and the community. So we have 2 groups, in fact. One, we are getting in the hospital, other one, the outpatient department and other diagnostic centers they're coming from the community. If you look at those, there is a difference between distribution of typhi and paratyphi in the inpatient compared to the outpatient department. So 16% versus 22%. If you look at the ratio in inpatient, it is 5 typhi and 1 paratyphi, and outpatient department 4:1. If you go back little further, so we saw in average it is 4:1 typhi to paratyphi. But if you go a little further, 2004 to 2014, we are talking about more than 5,000 cases of typhi and paratyphi. Then it was 6:1, and it ranged from 4:1 to 9:2. You can look at the fluctuation by year. It depends on the different factors can really change that the distribution of typhi and paratyphi who are coming to the facility and who are not coming to the facility. So antimicrobial resistance. If you look at the antimicrobial resistance in Salmonella typhi and paratyphi, in multi-drug resistant strains are there in the typhi, but none in the paratyphi cases. And multi-drug resistance cases are 20%. If you go back on the other side, bars is historically from 2005 to 2013. If you look at these cases, at some point we all reported in different journals that more than 60% of typhoid cases are multi-drug resistant, but it has come down to the level of 18 to 16%, so around 16%, in fact. If you can see some of the posters in the poster section, there are some other data also from India and other countries where the rolling down of the multi-drug resistance strains. And when we are talking about the multi-drug resistant strains, possibly one important issue will be coming as the haplotype 58, which is linked with multi-drug resistance, and it is expanding among Salmonella typhi globally. So everywhere haplotype is going on. And then we also try to understand what is the rate of this H58 in Bangladesh isolates. So in this SEEP's time, we had 264 salmonella typhi cases, and of those 102, that means 39% were with haplotype 58. And of those, 52%, that means 53, are with MDR. So all MDR cases were with H58, but all H58 cases were not MDR. So let's going back further, because the haplotype is not only restricting its impact on the multidrug resistance, it has also impact on fluoroquinolone susceptibility. If you look at this, the fluoroquinolone susceptibility, if we consider MIC50, we do not see any difference between H58 and non-H58. But if we go one step further, then you will see, in fact, there is a big difference between H58 group and the non-H58 group. At the same time, if you go to the ceftriaxone, there is not really any visible or any significant difference between this H58 and non-H58. If you go one step further now, so H58 lineage is becoming very important, and detailed studies are going on, because salmonella typhi, in fact, it was always difficult to do the molecular epidemiology. So the MLST or PFG, nothing was very successful, but this one lineage really helping us to do the phylogenetic tree and all these. So there's lineage 1 and lineage 2, the two different colors you can see. So we try to understand what are these, what kind of haplotype 58 we are having in Bangladesh. So we try to understand this, and interestingly, we have good number of H58, but all of them are lineage 1A. So there is not much diversity we are having till now. But possibly when I'm not sure that what was the situation, in fact, when it was more than 60% cases of MDR, that could be different even. So, and now the susceptibility to ciprofloxacin and ceftriaxone in typhi and paratyphi, you can see the differences between ciprofloxacin, MIC50 and MIC90, and paratyphic cases are more non-susceptible, as there were no MDR in paratyphi, but in the paratyphi cases strains are more non-susceptible to ciprofloxacin or fluoroquinolones. On the other hand, now if you want to look at the the genetic mutations, there is both of them, typhi and paratyphi, has similar rate of mutations, but contrast to that, the gyrase, the gyrase and topoisomerase mutations, gyrase B and the PARC mutations are significantly more in the paratyphi, and that possibly had the implication on the more non-susceptibility among the paratyphic cases. Okay, so conclusion, the preliminary data showed that we have huge burden of, though it is not yet from the population based, but we can really understand that we have a big burden of typhoid disease in Bangladesh, and ratio of typhi paratyphi is 4:1 as a whole, and it is consistent really for many years. And roll down of multidrug resistance, which is 25%. But however, we can see that we have H58, so it has a potential to come back again. Maybe the clinicians are not using the first line of drug anymore. That's why it is going down. And so it will be interesting to look at, if they start using it, what will be the situation then. There's a high rate of non-susceptibility of ciprofloxacin. And finally, we need continuous surveillance. At the same time, considering the high burden, we need to have the preventive measure, the vaccine, and also the wash and sanitation. Thank you so much. Thanks.
Thank you very much, Samir. Our next speaker is Farah Qamar from Aga Khan University, who will be speaking about looking back while moving forward with enteric fever surveillance in Pakistan.
Thank you, Rob. Good afternoon, and I thank the audience for staying till the very end of the day. So I would be first presenting an overview of SEEP in Pakistan, and then describe briefly the SEEP sites, for phase 2, and then describe the defining of the catchment area and the conduct of the healthcare utilization survey for SEEP 2. Then what the results that we have up till now, the preliminary data, I would be presenting some of that, and then describe the trends of AMR for typhoid. So in phase 1 of SEEP, we did a retrospective review of data it was at 2 hospitals, Khan University hospitals and a public sector hospital, Kharada General Hospital. For Khan University, we had blood culture confirmed cases for 3 years, 2012 to 2014. And for Kharada General Hospital, we had data for blood confirmed cases, culture confirmed cases for only 1 year, 2014. Phase 2, as you have already heard, is a prospective study. We started in October 2016, and there are 4 sites, Khan University Hospital, Kharada General Hospital, NICH, and the lab network of the Khan University Hospital. So Khan University Hospital is a private sector hospital, and from there we are enrolling both inpatients and outpatients. And from Kharada General Hospital, which is a public sector hospital, it's a charity hospital, we are enrolling inpatients and outpatients. The National Institute of Child Health is the largest public sector children's hospital, which receive referrals from all over the country, and this we are using to enroll surgical cases only. The clinical lab of Khan University has a lab network of around 200 centers all over the country, of which 30 are placed in Karachi. So we will be we have taken 4 centers where there is high turnover as sites for SEEP phase 2. These are pictures of some of the sites. At each of the entry points in each hospital, there is dedicated staff which carries out enrollments for the phase 2. Now briefly describing the approach to healthcare utilization survey that we used, and you have already heard from Alex, the hybrid approach. We used a similar approach for the healthcare utilization survey. So from phase 1, we identified the catchment area. We plotted the bulk of culture-proven cases for both the hospitals, for Khan University Hospital and Kharada General Hospital. For Khan University Hospital, we plotted the bulk of culture-proven cases and identified the 3 towns from where they were coming. And for Kharada General Hospital, because we had only 1 year data, so we plotted data of cases of fever coming to the outpatient department and identified the catchment area of that hospital. So this is how the map looked like when we plotted. The small dots, if you can appreciate, are the cases of typhoid, and then we generated a heat map. And the blue lines show the boundaries of the towns, which were included as the catchment area. And a similar approach was adopted for the catchment area for Kharada General Hospital. And then we overlaid a virtual grid on the catchment area, and from that, a random number of clusters were picked to conduct the household survey. And each household in that cluster was surveyed. The survey has been completed only last week. These are some of the pictures of the actual survey. There were logistic challenges, as Alex has already explained. Some of them were similar, that sometimes there were only females at the house and they did not open the door. And we approached each house 3 times to get the answers. Because of security situations, some of the upper middle class houses did not open their doors to us, but they answered all the questions through the intercom. So there were 240 total clusters. We approached 2,649 households, and we collected completed data collection in 2,382 households. And the results of this have not been compiled, but they will be used for age-specific population-based adjusted incidence calculations. So regarding the enrollment progress for SEEP2, which we have started from the second week of October, we have enrolled up till 754 cases up till now, of which 82 are blood culture confirmed. And we have 11 cases of ileal perforation enrolled so far. This is the age breakup of the cases of ileal perforation, and most cases are less than 15 years of age, and the youngest case being of 12 months. One of the child died, a 7-year-old, and rest of them all are doing fine. So if we compare the demographic data of SEEP1 and SEEP2, it more or less looks the same. Roughly 22 to 23% of the cases are in the age group of 0 to 4 years, and most of the cases are between the age of, 50% of the cases are between the age of 5 to 15 years of age. So these are the number of cases amongst children 0 to 5 years of age for SEEP phase 2. So there are 29 culture-proven cases in children less than 5 years of age up till now out of the 82 culture-positive cases, which is roughly 29 to 30% of the cases. This is the trend of typhoid for Pakistan. You see that overall the disease is endemic throughout the year, but it peaks in between April and October, but it quite never goes down to a very low level. It remains there throughout the year. Oops. So the 5-year data that we have now for antimicrobial resistance for typhoid, we see that MDR has remained high throughout for typhi. It is between 50 to 60% of the cases of Salmonella typhi are MDR. But for paratyphi, it has always been low. So looking at the trend of ciprofloxacin resistance for the 5 years, it has again remained above 90%, and in this survey, it is now approaching 100% for both typhi and paratyphi. So typhoid remains still a big public health problem in Pakistan. It is endemic. There are high rates of MDR and fluoroquinolone resistance, and this has severely narrowed the therapeutic options, especially for the outpatient department. There are high rates of intestinal perforations. 80% of the cases are Salmonella typhi, and even a monovalent vaccine will have an impact in disease control in Pakistan. So this is a picture from this SAPOT and SEEP visit to Pakistan. And I thank all the collaborators, the Sabin Vaccine Institute, the Gates Foundation, SAPOT, and my research team in Pakistan.
Thank you. Now for our final speaker of the day. Dipika Sir from the Translational Health Science and Technology Institute will be presenting a retrospective review of hospital-based data on enteric fever in India.
So good evening, everybody. And it's not very enjoyable to be the last speaker of the day, but I won't keep you for long. So we did a retrospective study, as Denise has explained. We did the phase 1 of the enteric fever SEEP study. We did the retrospective review of existing hospital data. And so the, okay. Which one do I put? Is it this one? It's down. Oh, so it's like, okay. Okay. So an overview, giving an overview, India really lacks a nationally representative database on enteric fever, and there is extensive underreporting. We tried to analyze some of the data that was available. We practically got no data from hospital-based studies, and in community-based studies, we see that there are about 2 to 5 per 1,000 person years, the incidence, and the highest is seen in children less than 15 years. And another, not interesting, but an observation that we saw was that the intestinal perforation cases, especially the ileal perforations, the terminal ileal perforations, which are actually so pathognomonic of enteric fever, we hardly have any data on mortality and morbidity, at least linked to enteric fever. So there again, we wanted to know more about these issues. And the objectives was therefore to estimate the burden of hospitalized severe cases of enteric fever, inform the policymakers on development of effective policies, and to promote new vaccine development and utilization. So regarding the methods, as we said, it was a retrospective data collection, and the study period was 2014 and 15. That's 2 years. For case definition, we used lab-confirmed cases, patients with a positive lab culture for S. typhi or para. And for surgical cases, we took patients with intestinal perforation regardless of the culture status, and then we tried to analyze the data. So the data sources was like this. Initially, we collected the electronic lab data, which all the culture confirmed cases, we collected the electronic lab data for the organism and the demographics, and then we tried to corroborate that with the inpatient charts, clinical manifestations, complications, antimicrobial resistance, etc. And for the intestinal perforations, we again went through the surgical charts. So these are the 5 hospital sites across different parts of the country. We had one in Chandigarh, Postgraduate Institute of Medical Sciences, Medanta Hospital in Gurgaon, Apollo Hospital in Kolkata, Christian Medical College in Vellore, and Kasturba Medical College. So it was covering practically the whole country. So coming to the distribution of age in years by organisms. So the red is typhi and the blue is para. So we see that there are, for typhi, there are 2 peaks. A smaller peak, less than 10 years, and a larger peak, 15 to 30. And the same with para, but the para, there is no peak in the initial age group. And over time, we tried to see the temporal trend, and there we see that it is more or less throughout the year. But one interesting feature was in Medanta Hospital, that is in Gurgaon near Delhi. There was a big peak in 2014. And this, of course, needs to be explained because obviously there were cases in the community, higher number of cases in the community which were coming to the hospital. Coming to the clinical features of the lab-confirmed inpatients, we also did inpatient and outpatients. So coming to the inpatients, there were 597 lab-confirmed. Just a minute, I think I missed out one. Okay, so there were 597 lab-confirmed inpatients, and of that we could abstract 429 charts. From the laboratory, it was actually electronic data, and for the clinical part, we had to abstract from the paper charts, and therefore we couldn't get all of them, so we could only recover about 72%. Of this, 362 were positive for S. typhi, that is 84%, and 67 were positive for para. Now, the clinical features between the two, S. typhi and para, fever was there practically in all cases. Nausea and vomiting was significantly higher in S. typhi, and there was weakness and malaise in 34% and 46% cases, S. typhi and para. There was headache, there was abdominal pain. Again, diarrhea was significantly higher in the S. typhi cases. There was cough, difficulty in breathing. Skin rash and rose spots were more in S. typhi. There was decreased consciousness. Blood in stool was seen in S. typhi cases, and there were some cases of constipation. Then looking at the antimicrobial resistance is more or less similar to what we've been hearing throughout. Regarding the initial drugs that were used, that is cotrimoxazole, ampicillin, chloramphenicol, etc., which we used to think of as multi-drug resistant strains, now they are most of them are susceptible. Ciprofloxacin is still an issue. It's very, the high resistance for both typhi and paratyphi. Ceftriaxone, as of now, is the drug of choice, which is being used regularly. Azithromycin is not being used too much, yet the resistance pattern is increasing. And then we tried to see between the 2 years, 2014 and 2015. Here again, it was more or less similar with a little more rise in ciprofloxacin resistance. Okay, so the lab confirmed in patients, there were some, the complications that we saw in the lab confirmed in patients. We see that there were hepatitis, 26 cases had hepatitis, 11 cases had encephalopathy, 10 had renal impairment, 7 had shock, 6 had GI bleeding, and there were 5 deaths. There were 3 intestinal perforations that was identified as lab-confirmed cases. And there was myocarditis and other complications. I have missed some of the slides are missing. Anyway. Okay. So the interesting findings that we got were that the corporate hospitals or the for-profit making hospitals, which have high-profile clientele, they also identified large number of enteric fever cases. And you know, because the usual idea is that it's really seen in the lower socioeconomic group, but here we found a lot of cases in the higher socioeconomic group. And the age groups most affected was, as I said, 2 spikes, that is less than 10 years, and one was 15 to 30. Now, this will be very important in future when we try to identify the age group for the vaccination. Now, the samples collected from the site of intestinal perforation, what happened was mostly the surgeons didn't collect samples for the intestinal perforation cases, and if they did, they were collected from the site itself, whereas the microbiologists would prefer a duodenal aspirate, which would be more specific. But most of the times, the samples were not collected from the perforations, and that is how we have much less data on the intestinal perforations due to enteric fever. Regarding antibiotic sensitivity, as I said, ceftriaxone presently is the drug of choice. And the temporal distribution of cases in Medanta Hospital, which we saw in 2014, indicates an increased number from the community, and therefore, although this study gives an insight of the magnitude of severe cases, community-based surveillance will be needed for assessing the total burden of disease for making policy decisions. And finally, acknowledgement to our institute, THSTI, Sabin Vaccine Institute, Denise and Caitlin, and the other institutes where we conducted the studies, all the 5 hospitals. Thank you.
We now have ample time for questions on any of the presentations, so please feel free to come forward to the mics. Andy?
Yes, so I just wanted to raise this issue of the apparent small number of cases in younger children which appeared in several of the slides. And I think it's important just to think about how that could be wrong rather than real data. And there's a number of reasons that we've thought about because we've seen similar patterns in some of the studies that we've done in Kathmandu. So just to backtrack a bit, I've been working with pediatricians at Patton Hospital for 12 years, doing pediatric studies, looking at invasive bacterial infection in the hospital. And in those studies, we see loads of typhoid in children under 15, including very young children. When we did an outpatient study, which is trying to capture everyone with fever, we had about 15% of the febrile children having positive blood cultures. But we talked to the pediatricians there, and the majority of those children, they wouldn't have routinely tested, and they would have just given them antibiotics and sent them home. So it may be that part of the reason why we don't capture lots of cases is just because we not routinely taking cultures in those young children. The other finding from that outpatient study was that a third of the children presenting had less than 3 days of fever. So that means that if you only have 3 days of fever as your definition, you're missing a third of the cases potentially, assuming that's the same in all other settings. And there's another particular problem in Kathmandu in that there's so many hospitals now that my colleagues from Nepal can't remember how many there are when I asked how many there were in Kathmandu. But we do know that most children go to the 2 pediatric centres, which is Kanti Children's Hospital and Patan Hospital, and not to most of the other hospitals. And then lastly, we've been doing a healthcare utilisation survey as part of our work in Strata, and in our population of about 100,000 people. And what we found there is that the primary place that parents go with their child when they have fever is to the local pharmacy, and there's often a doctor in the pharmacy anyway working privately, so we're not even getting them to the hospital in the first place. And it turns out that in our population of 100,000, there's somewhere near to 800 pharmacies, which means there's one pharmacy for every 125 people. It's not like that's everywhere, but that's really means that it's much more accessible to go to a pharmacy and get some over-the-counter drugs than to go to a hospital facility.
Well, thanks, Andy, for your comments. And the data I showed from Nepal is actually from Jason Anders. He's the PI in Nepal, and I think it's fair that he addresses your comments, but I can say he has done like the same curve that I showed, he has done in proportion, and what he saw was that the burden between 15, and I want to represent you well, Jason, 15 to 25 years old is 9 times higher than under 5. So I don't know, Jason, if you want to add anything else to this? Okay.
I'm not criticizing. I'm just saying that this is a problem that we have in trying to identify the burden. There's lots of reasons why children might not get blood cultures.
Oh yeah, I know, and that's why we're doing SEEP phase 2, because with the healthcare utilization survey, we're going to be able to actually show population-based incidence stratified by age.
Okay. Sam?
Yeah. Wonderful talks. My question really is to the pediatrician from Aga Khan, Farah. Thank you very much for that talk. I was just wondering, I've seen extremely high levels of resistance to fluoroquinolones, and then surprisingly, very low levels of resistance to, the first generation beta-lactams like ampicillin and other drugs like chlorphenico. Are we then turning towards using what we discarded in terms of antibiotic resistance some time back? Or what's your take on this? And what are the current drugs of choice now for treatment of typhoid in Pakistan?
So, high rates of ciprofloxacin and MDR are prevalent, and the reasons are the same as was described by Andrew for Nepal, that people seek healthcare at pharmacies, over-the-counter drugs are available freely, and there are there's a great use of these medicines, especially ciprofloxacin in veterinary medicine. That is one of the major causes that we have identified. So the current choice of treatment is cefixime for outpatient and ceftriaxone for inpatient treatment.
Gentleman in the middle.
Yeah. So Dennis, my question is for you. The thing is, in my study also, and in your work, and in all the work, starting from Pakistan, then northwest and western India, then in Bangladesh, including Nepal and China, we are getting similar pattern of MDR. And we are getting similar pattern of fluoroquinolone resistance. But in one abstract, I found that not much fluoroquinolone resistance and 100% susceptibility to third generation cephalosporin was found in a big study in southern India, that is in Bangalore. So was just thinking, if you have one center for your study in the southern part of India, and then you can actually find out whether the resistance pattern is different in the southern part of the country, because this is forming a belt. So what factor would be contributing to making this belt just above the southern part of India, in India, Bangladesh, Nepal, China? So why the H58 strain is over there? Why not below? So that can be a thing. And a second point is,
Can I answer the first one first?
Yeah.
Before I forget it. No, it's a good question. Thank you. We did have 2 sites actually in the southern part of India. The data that Dipika showed is the overall for all sites, and I think we did
CMC
analyze separate. And Dipika, I'll let you maybe address this question. She did not show, but we can show you later the analysis by site and compare, between the southern part and the northern part of India.
Okay, and the next part I would like to add to the person who questioned just before me. So the similar finding has been observed. In 1980, we didn't have an MDR, and the MDR resistance pattern just started developing since 1985, and it was a ACCOT pattern. In 1990, it increased and it became similar. But since 1995 in India, that pattern is going down, whereas the plasmid-mediated quinolone resistance pattern is going up. So there should be one study whether use of a particular antibiotic over how much period of time it is causing or an increase in emergence of resistance, and discontinuation of that antibiotic, how much time is required to actually increase the susceptibility to a particular level, and whether it is a cyclical pattern or not. So, thank you.
Hello, yes. Masunda from Zimbabwe. I've got a couple of questions to the different speakers. The first one, I think, goes to IVI and the SETA program. Is there any special reason of the sites that were chosen to do that program? And then my second question is to the last speaker. It's an observation that we've made also in Zimbabwe that there are more, in terms of symptomatology for typhoid, we're seeing more diarrhea than constipation. But when we were in school, or even the books, they're still speaking of more constipation than diarrhea. So maybe is the pattern of disease for typhoid changing? Then the last one is for, I think from Pakistan, where you're saying you're now using cephalosporins for management of typhoid. What I want to find out is, are you using the oral or intravenous? And because of the cost of the cephalosporins, is this being managed through the public health system, or it's through the private system? Thank you.
I can answer the first question. So the site selection for the CEDA sites came partially out of the TISA program to look at the high burden sites and then carry that forward to see what's the burden of severe typhoid fever. And the additional sites, Ethiopia, Congo, and Nigeria, they are priority countries from the foundation, so that's why they were included.
And then more.
Good turn. Go for it.
So,
Okay. Well.
You asked me about the cefixime and ceftriaxone. It is available both in the public sector hospitals. It is provided free of cost where needed, but in the private sector hospitals and at the pharmacies, people have to actually purchase the drug if prescribed. So it's both systems. It's not free of cost for everybody.
I have a
John
question
Clemens.
for the disease modeling effort. I commend you on this. But I wondered, from looking at the data sources that you are using for reports, whether you're really identifying where typhoid is not usually there and is a surprise and therefore newsworthy, as opposed to areas where typhoid is perhaps with a higher burden, but part of the usual endemic landscape of disease. For example, you'll never read anything in the DACA newspapers that our diarrhea hospital has just received 1,000 patients of cholera. It's totally expected, and it's not unusual. One way of addressing this would be to validate this system and these decision trees against your TSAP sites, which had variations of documented incidents. Have you done that?
So last figure that I showed, to trying to identify the relationship between the instance rates we observed in different sites, and they have some sort of pattern you observe, like high instance rates is correlated with somewhat with high risk of typhoid we have observed, predicted. That's one thing we did. And in general, I think we pretty much just rely on the data that's available, like identified sites. And we just use, one thing we did, just, as I showed, like a tenfold cross-validation. You just took the part of the data and tried to predict the rest of it. And that's how we validated model.
Mike.
Great. This has been a great session that's covered many important topics, including burden, importance of typhoid in very young children, the prevalence of multiple drug resistance, and I'm trying to absorb it all. What strikes me is that typhoid in the developing world, in particular Asia and Africa, is an elephant. And what we've heard are presentations of tusks, tails, left hoof, right hoof, and everybody's right. And I think this is a very important point. Do not think because you have measured a tusk that the whole thing is a bigger tusk. It's an elephant, and everybody's right. Over the decades, what one sees is that there really is heterogeneity in the geographic distribution, in the age distribution. This is a human-restricted pathogen. It is spread in different ways. It depends upon local customs and feeding and child care practices. It makes sense. So in terms of some of the descriptions, I'll share a couple of points. In terms of looking at typhoid in young children, when we started to, in the early days of the typhoid fever control program in Chile, we had low incidence of hospitalized, culture-confirmed typhoid in the hospitals. That was real. And we wondered very early on, why is there not more typhoid? Are kids not being exposed? Are they somehow protected in the first year by breastfeeding or maternal antibodies, whatever? We did a study. Caterina Ferreccio, raise your hand, this first author on this paper. It was the first time anybody systematically, routinely in typhoid season, drew a blood culture, 2 mils, old-fashioned bacteriology, from every kid who walked through the door at health center. We sent down a chief resident of pediatrics from Maryland, and he was involved with the study. And after about a week or 10 days, he said, Mike, if any of these kids grow typhoid, I'm going home. And of course, cultures came in 4%. 1 of every 25 kids had an enteric fever pathogen. So what we saw in the hospital was real. There was bacteremia in kids, but that was a different disease in Chile. It doesn't mean it's the same everywhere, but in Chile, with old bacteriology, by the time we got the culture, went back, recultured the kids, they were well. They got antibiotics, but they really didn't need antibiotics. The blood cultures were again negative. In other places with a bigger inoculum, whatever the reasons, things may be different. And we heard this morning, as one example, Cal McLennan's presentation of the RTSS, systematic. Every kid, including infants, coming into hospital gets a blood culture. It's hard to believe in the places where there was not typhoid grown that this was some defect of selection. Moving on, antibiotic resistance. I also don't have a good feel of what's going on. And this is very important because in the next few months, it would be important to have a link of increasing antibiotic resistance or it being a stable situation where we're only 1 or 2 drugs away from treatment. But what I heard today, again, was parts of the elephant. I've heard from several places that multiple antibiotic drug resistance is going down. That's a different message from some other places where there's virtually untreatable. On the plane, I heard about an outbreak in Pakistan with a bug that's resistant to everything. This is important. And I'll share one other thing. When typhoid disappeared in Santiago, there was this infrastructure that was expanded, and we picked with the Ministry of Health another pathogen to attack. And the pathogen was pneumococcus, looking at invasive disease. And just as some of you beautifully described, setting up surveillance at different levels, there was surveillance of inpatients, surveillance at emergency rooms, surveillance at something called SAPUs, which is kind of a giant, 24-hour-a-day emergency health center, and then health centers. And at each of these places, the disease scene was different, to the point where this is 14 years of surveillance in a huge, in an area that included 600,000 people where the strongest surveillance was done. But anyway, what it showed was even there were certain serotypes. 18C was seen only in bacteremic patients and outpatient. We never saw that in inpatients. Just to show that bugs make a difference, and there really is this pyramid that you described. And with other bugs, cholera. If Vibrio cholerae 1 did not cause cholera gravis, would we have a stockpile? Would we really have a cholera vaccine for emergencies? Probably not. The most extreme case, polio. If type 1 polio, which is the last serotype left, did not cause paralysis, if it only caused some diarrhea and vomiting and a bit of fever, would we have a polio vaccine? No. I think the same thing is with typhoid. It's the severe typhoid that we want to prevent in one way or another. And the antibiotic, somehow before we leave this meeting, we've got to collectively come to grips on some sort of global pattern and which way things are heading.
Thanks, Mike. Samir, is there a part of the elephant you'd like to comment on?
So, Mike, I just will add one thing with your comment about this multi-drug resistance and outpatient and inpatient issues. the cases, the treatment of typhoid is very different in the developed part of the world and developing countries, I mean the endemic countries. The typhoid is treated in UK, US, and possibly also in Canada. Is you will be isolating that child, you'll be keeping in a facility, and this is the way you treat them. If you come to Bangladesh, India, and Pakistan, they're being treated in the community. They're only coming to the hospital when you are really there, there's treatment failure. If they're giving ciprofloxacin on the cane, they are giving it. When ampicillin, cotrimoxazole, and chloramphenicol was working, they were giving those. And they were only coming to the hospital if the private practitioner treatment is given, the pediatricians, they'll be coming to the hospital. We published 2 small papers, in fact. One, 70% multi-drug resistance. And we published, Kolkata published, ICDLB published, all of us published. What we did not stop there. We continued to work in addition to the hospital where screening out all the multi-drug resistant strains and coming to Samir Saha sitting in a microbiology lab. What we continued to do, work with the private practitioners who are practicing in the community. And we found 70% in the hospital multi-drug resistance, but only 25% in the community, where 80% cases were being treated. So the scenario will never be consistent if we are not doing a comprehensive surveillance, taking all the modalities in place. I believe, I do not know the detail of SETA, but in SEEP, the way it is being designed, I believe we'll be really capturing all those cases and giving you the right answer, what is the scenario of multi-drug resistance in this part of the world.
Thanks, Samir. We have a few questioners. Let's give a chance for this other questioners to ask questions. They've been standing for a long time. Ginny.
Ginny Pitzer from Yale, and my question's for Denise and for Dipika. I was just wondering whether you looked at the age distributions, particularly in Kathmandu and in India, broken down by gender, because with our colleagues at Patan Hospital in Kathmandu, one of the things that we've seen is that second peak in the 15 to 30-year-old age group was predominantly occurring among males rather than females. And I was just curious whether the similar pattern was being seen in your data from Kathmandu and the data from India. It was both in Kathmandu and in India, that second peak in the 15 to 30-year-old age group, and whether that varied by males versus females.
I see, yeah. Do you want to? Shall I answer the Indian? Yeah. Well, actually, somehow I had missed 1 or 2 slides when I was talking. So we saw, I wouldn't say the peaks, but generally, overall, there were more male patients than female patients, and they were significant, the difference in para and typhi.
Buddha.
Thanks. Buddha Basnet, Patan Hospital, Nepal. I would like to, if I may, extend Dr. Levine's comparison of this elephant. I think there's an elephant in the room, and the elephant in the room that we're not addressing is this combination drugs that are used extensively in South Asia to treat typhoid. For example, like top of the chart is ofloxacin versus azithromycin with teeny homeopathy dosage of ofloxacin, 200 milligrams, and azithromycin, 500 milligrams. So this, I think, this is more like a commentary than a particular question. But I think this is used a lot, and so azithromycin combinations, ofloxacin, cefixime and ofloxacin combinations. This part, South Asians love to use combination drugs, I think. I mean, it might be a good thing to, with going for infectious diseases to use 2 drugs, but this needs to be addressed. I think this is another issue. The other thing that I have, we did a study many years ago, 2006-07, randomized controlled trial from Patan Hospital looking at the cefixime did not work, and we had to stop this study in the middle of the study by the Data Safety Monitoring Board. And although cefixime shows up sensitive in vitro, in our study it wasn't. So I think this is, although this is a 3rd generation cephalosporin, this doesn't seem to work. I haven't seen other studies after that study where a proper sample size was done looking at this. This is just a commentary I wanted to make. Thanks very much.
Thank you. So last comment, Anita?
So there's another age distribution setting related issue as well, which I think applies to the Pakistan and India sites where they are enrolling from private hospitals, which can affect exposure distribution, because in these private hospitals it's a middle to upper income population, and they may have lower exposure in the younger age groups because they're brought up in a different way, and it's only when they start going to school and as well as work where other exposures might happen. So whereas Bangladesh is a public sector, intense transmission, they're capturing all of the poor people. And Nepal has I think the issues are more to do with the sorts of things that Andy was talking about. So just to be careful when you interpret your findings from the retrospective. The antimicrobial resistance issue is looking really interesting because it looks like countries are very different, and even in South Asia, India, Bangladesh, and Nepal are reporting low MDRs, but Pakistan is reporting very high MDRs and hasn't gone down. It'll be interesting to capture prescription information, like what are the first lines for febrile illness, and perhaps part of your healthcare utilization survey could do that to see if there's much more antibiotic use happening in some populations versus others, because I'm surprised that Bangladesh would be similar to Nepal. I mean, it would have a lot of antimicrobial use. So how come have they completely moved away from using cotramoxazole and ampicillin, and everybody's getting the quinolones, or what's happening out there?
Two things. Onita, we are also enrolling the cases from the most expensive private facilities, which are very pricey, in fact, double blood culture price and double the visits for the private practitioner. And what is the second question? Oh, yes. So it is, number one, clinicians are very tempted to take you the message when you were talking about drug resistance. They'll be going to the next generation, number one. And number two, we have now many pharmaceutical industries in the country itself. And if they're selling maybe 10 doses of cotrimoxazole, which will be they're making more profit with 1 dose of ceftriaxone. So companies themselves are also promoting those drugs. In fact, that's another important thing. And we do not get, when we did a trial of cotrimoxazole for pneumonia, we really could not buy cotrimoxazole. We had to order that cotrimoxazole and get the cotrimoxazole there. So there is no way you can use it anymore. So we are requesting government to subsidize these drugs so that these drugs remain available for us.
This will be an opportunity to look. Farah? Okay, go ahead, Farah.
For the Pakistan site, I would say it's not just one private sector hospital that we are enrolling from. There's a charity hospital, the Kara General Hospital that I mentioned. And even in the private sector hospital, we have at any one point in time, 25% of the beds allotted are for free. They are on welfare. So I think we are looking at the under-impoverished population as well, but it is a good suggestion to incorporate a question in the next healthcare utilization survey that we do.
And this will also be an opportunity, I think, in some cases to look at clinical outcomes in patients with a drug-resistant strain who are treated with a drug to which the bug is resistant versus not. I think that's going to be important because we've all been talking about the specter of returning to the pre-antibiotic era, and it will be useful to document what those outcomes are when the strain is resistant and the bug is treated with a drug that is resistant. So I want to thank the panel for wonderful presentations. One gets a feeling that there'll be a lot more the next time this conference occurs in 2 years. It's going to be a very robust set of data. I want to thank the audience as well for great questions.